shall now go on to our keynote speaker, Dr. Craig CHAYA, and who's going to tell us something very much more relevant to us today. He's going to be talking to us on iStent and introduction to the technology and suggestions for achieving a perfect result. And on to you, Dr. Craig.
Okay, thank you very much. Let me share my screen. Are you able to see my screen?
Yes, yes.
Okay, great. All right. Well, good evening to all of you. It's good morning here in Salt Lake City. I just want to thank you so much for the AIOS committee for inviting me to speak on this topic of trabecular bypass technology and tips on achieving optimal results. I have a few disclosures. I have served as a consultant for Ivantis, who is the originator of the Hydras micro stent, and I've done some consulting work for Allergan, which is not pertaining to this topic. So the first thing I'd like to discuss is the iStent. Many of you are excited to be using the iStent, and this is the first generation iStent that I'm showing you on this slide. This was the first MIGS device that came to market in 2004. It was CE marked, but it took quite some time before it was FDA approved here in the United States. In 2012, it was FDA approved. As you can see, this is the original, what we call G1 or first generation device of the iStent. There are many different active parts of the iStent that I want to draw your attention to. Here is the inlet, or what we call the snorkel. And then there's also retention arches along the iStent. You can see them here in this picture diagram here, where there are 3 retention arches to help maintain the position of the iStent in Schlemm's canal. There is also a very sharp tip, the self-trephining tip, that is used to puncture through the trabecular meshwork, and then the device is slid into position. You can see the device is very small, only 1 millimeter in length, okay, with an 120 micron snorkel internal lumen, which is in this location right here. Now, this is when you receive the iStent G1, it comes in 2 different versions. There's a left version and a right version. Now, these do not determine the laterality of the iStent, but really determine the direction of delivery. So whether you are a right-handed surgeon or a left-handed surgeon, you would want to use the left or right version depending on your comfort. For me, I'm a right-handed surgeon. So traditionally, if I'm placing one iStent G1, I tend to go to the left, which is easier for my hand position. But sometimes it's important to go the other direction because maybe you can see that there's better flow patterns in that area, either based on pigment, or you can see some blood behind Schlemm's canal, or preoperative, I've identified on the limbal areas some areas where there's some aqueous collector channels and aqueous veins, in order to try to target that high efficiency area. So this first generation, again, there'll be a left and right version. So depending on your hand position, you'll choose a left or right version. This is MRI conditional. What that means is that for most patients that are receiving an MRI for other issues, it is safe for 3 Teslas or less. And that's what is in the directions for use. 3 Teslas or less, it is considered MR conditional or MRI conditional. Then there is the next generation of the iStent, which came out a few years ago, called the iStent Inject. And as you can see, it's also made out of a similar material. It's heparin-coated titanium. And instead of actually placing the iStent to the left or to the right, you can actually place this perpendicular to the trabecular meshwork. And so as you can see, it's a very small stent as well, with a very small internal lumen of 80 microns. In addition, this portion has side outflow outlets, which is the head of the iStent itself. There are 4 holes with 50 microns each in diameter to help produce lateral flow. Again, this is MR conditional for 3 Teslas or less. Now we come to the newest iStent, which is called the iStent Inject. And as you can see, it's a very similar device, except it has a wider flange. And what we learned from the iStent Inject is the iStent Inject, because the original flange, I'll go back to this photograph, the original flange was very small, about 230 microns in diameter. And what we found that it was easy to deploy the device too deeply and almost past the back wall of Schlemm's canal. So some modifications were made in order to enlarge that to 360 diameters for the flange in order to prevent that deep penetration and insertion of the iStent inject. So hence the name iStent inject W, W for the wider flange. Again, it's heparin coated and it is safe for 3 Teslas or less in MRI. Here is what the delivery system looks like. I want to draw your attention towards this first diagram here. This is the actual working portion of the device. You can see there's a sharp tip trocar inside of this barrel. And it's very important as we deploy this iStent inject to pay attention to this trocar. And sometimes you have to turn axially the handpiece so you can see this trocar more clearly in order to make sure that you don't introduce any trocar bias, which will prevent deployment of the iStent. It is a 23 gauge sleeve, and it's a nice ergonomic handpiece. There's a retraction button here that you will slide back, and then you will press this button right here in order to deliver the iStent. The iStent Inject W comes with 2 iStents preloaded on the device, and it gives you 4 clicks in order to deploy those iStents. Unfortunately, with this iStent Inject W, after 4 clicks, if you have failed to deploy any of the iStents, it is no longer usable and you would have to open up another one or manually insert them with a micrograsper, which would be challenging. In the new release system that will come in the future, the iStent Infinite, this will include 3 iStents on the handpiece and will include infinite deployment clicks so that if you misfire, it's okay. You'll be able to do that again and reposition those iStents as needed. And the advantage again is that it will be unlimited clicks in order to deploy the iStent, and it will come preloaded with 3 iStents. This is just a diagram showing you that during the insertion, you'll be working out your main incision, typically your temporal incision, if you sit temporally, or you could work through a scleral tunnel, and you could also work through a superior clear corneal incision as well. Again, these devices are meant to be spread apart, anywhere from 2 to 3 clock hours, but as I'll show you in a video, it's not always possible, just maybe because of positioning or where you place the first iStent. These are my tips for optimal results, for achieving optimal results. With all of these trabecular bypass stents, it's important to have an en-face gonio view. And what I mean by that is you want to be directly looking at the trabecular meshwork rather than looking from the top-down position where you're looking mostly at the iris and looking at the angle. You really want to be able to visualize all of your landmarks and to be able to look straight on en face with the gonio view. The G1 stent has a few little peculiar things about it. With the G1 stent, because you are deploying the device in a lateral direction, it's important to pierce the TM at a 15-degree upward directional control. And then with the iStent Inject W, when you're deploying the device, it's easy to use just your index finger to press the button to deploy, but by doing so, you may strum the device and cause the iStent Inject to deploy incorrectly. And so what I teach our fellows and trainees is that as you're deploying the new iStent Inject W, is you want to pretend to squeeze the entire handpiece with all of your fingers at the same time in order to prevent any bias or strumming of the shaft of the device, of the injector system. You want to gently dimple the trabecular meshwork before deploying, and again, avoid trocar bias. So this is one of my fellows performing the iStent Inject W, and we'll retract the sleeve, and then we've got good view of the trabecular meshwork. And as you can see, my trainee now is deciding which way to go. And we've decided that we were going to go initially to the left, but this is a right eye. Theoretically, there are more collector channels in the inferior nasal quadrant. So we're going to deploy here the second iStent Inject, but you can see the iStent doesn't deploy and it is still on the injector. So we'll move across and try to do it again. And remember, we only have 4 clicks. So that's now 3. We misfired twice. And finally, we're able to achieve the 4th click. You can't see it very well. It's hidden by some of the reflux of heme, but the first iStent was deployed here, and the second one was here. This is a little bit close, Ideally, we would have wanted to deploy this maybe 2 or 3 clock hours away to try to accommodate a larger surface area of targeted tissue. Okay. This is Dr. Ike Ahmed. Dr. Ike Ahmed is, many of you obviously know him, a very influential personality and surgeon in the MIG sphere. And here you can see his video on the original iStent iStent G1. Dr. Ahmed is now our director of the Glaucoma Center, or the Crandall Center for Glaucoma Innovation here at the Moran Eye Center. We're super excited about that. And here you can see the first generation G1. And as you can see, there's going to be a slight 15-degree approach. He'll use that sharp trephiniting tip to engage and then level off and then slide laterally to the left. And then he will deploy, releasing from the injector. And then he'll use the injector itself to tap a little bit to make sure that it's well seated. You want to make sure that you have all retention arches covered, and the iStent snorkel should be looking almost directly at you rather than facing either down or up towards the cornea. Okay, so that is the G1. Actually, I'll go back to the video again. He's now showing you going in a different direction. As I mentioned, the iStent G1 has directionality, either going to the left or the right. This is now going to the right. Again, you slip in that self-trephiniting tip and then slide laterally. You'll see it slide into the trabecular meshwork. If you feel that the eye is moving and not deploying smoothly with the iStent, it's important to realize that that sharp tip is usually hitting the back wall of Schlemm's canal and is engaging the back wall. So you have to, in retrograde, pull it back a little bit, level off a little bit more flat, and then you'll be able to slide. This is, again, another iStent. Dr. Ahmed is placing 3 iStents. He's now using a left-handed, his left hand to deploy this iStent to the right. Again, you can see it slip just a little bit when you know you're in the right spot. Again, deploying, and then he will use the injector to tap it into position to make sure it's stable. Now viscoelastic removal just to clear the view, and there you can see very nicely 3 iStent G1s placed roughly about 2 clock hours away from each other. Okay, moving on to our next trabecular bypass stent. The Hydras micro stent was next to market. It was CE approved in 2017, and then FDA approved here in 2018. As you can see, it's a considerably larger device. The original G1 was 1 millimeter. This is 8 millimeters in length. It's made out of a nitinol alloy, which is a nickel titanium alloy, and it will achieve 3 clock hours or 90 degrees of treatment area. Just like the iStent, it is also MR conditional for 3 Teslas or less. This is the delivery system. It's a handpiece. It does not come in left or right versions. And the reason for that is that it has a rotating cannula that you can use to either go to the left or to the right, depending on your dominant hand position that you'll be using. There's then a tracking wheel. The tracking wheel is then used to deliver the system or deliver the Hydras microstent into the canal. One very important thing is that unlike the iStent, where you can work out of your main incision, you'll have to make a separate incision for the Hydras microstent, roughly 4 clock hours away from your targeted area. Here you can see this is a diagram for a right eye. And for a right eye, you want to target this area right here nasally, and you'll be making a separate paracentesis, 1 to 1.5 millimeters, approximately 4 clock hours away from the landing zone. Same thing would be for your left eye. Here are my tips for optimal results. Just like the iStent inject, it's important to have an NFOS gonio view. Now for the Hydras, because we're making separate incisions, I also like to label my incisions and the insertion site with a marking pen on the cornea. I think this helps in order to know where your paracentesis is under the gonio prism, and also to give you a reference mark on where you want to land with the Hydras. You want to be in the nasal area in order to give you room for the Hydras microstent to flow into Schlemm's canal. Again, you have to pierce 15 degrees upward, similar to the G1 iStent, in order to pierce through the TM and then you really want to stabilize your hand in order to allow the injector system to hold still and not retract backwards, because doing so may actually cause the device to pull out of the trabecular meshwork. On the injector system itself, there is a curvature of the injector, and you want to reduce the gap between the back of the injector and the canal to allow it to sit flat against the canal. Unlike the iStent inject, this is a really important tip, is to avoid overfilling with OVD, because if you tend to overpressurize the anterior chamber, you will collapse the canal and make it more difficult to actually deploy the Hydras microstent properly. It'll tend to catch and it'll be very tight. Finally, it's important to verify that all 3 windows are under the trabecular meshwork to make sure the Hydras did not prematurely exit the canal. Here's a video I'm going to show you first. Again, I'm a right-handed surgeon. I'll be using my right hand in this video. This is a separate paracentesis 4 clock hours away. And then we'll approach the TM. And this patient has a very lightly pigmented TM. Initially, you think that's the TM, but that's actually ciliary body. The darker line will be at the top of the trabecular meshwork. And I think my video got cut off a little bit, but here you can see it's deployed, and I'm now using a micro grasper in order to improve the positioning of the Hydras microstent. It's important to make sure that the Hydras inlet is the only portion that's uncovered. There's a transition zone that you want to make sure that is covered by the trabecular meshwork. And now we're going to be using a gonio prism here just to verify the position of the Hydras microstent. We'll turn the eye back to coaxial view. And then this is a Ahmed gonio prism, binocular instruments in order to view where the Hydras is. And here you can see we're looking, and you can't even see the tip of it, but there with the gonio view, you can see. I'm going to pause the video for just a moment so you can appreciate that this is the inlet and this is the transition zone. The manufacturers and the company will usually teach you to cover half of this transition zone with trabecular meshwork. I prefer to cover at least 75% of it to prevent any premature extrusion of the device. So I like to have it well seated with mainly just the inlet showing or uncovered by trabecular meshwork. We'll now show you, this is using my left hand to deploy. Again, 4 clock hours away from our landing zone in the nasal quadrant. And this view is a little bit suboptimal, but I'm rolling out the device and you'll see it very quickly roll out into position. We'll pull away carefully. And then again, we'll use a micrograsper coming through my temporal clear corneal incision in order to deliver, and then finally verifying with Ahmed gonio prism in order to verify that the stent is in position and that all 3 windows of the device are correctly deployed and covered. That's all for my talk this morning. I appreciate your time. I'm happy to facilitate or answer any questions that you may have.
Yeah, that was a wonderful presentation, which we all needed to see. But the first question is, after watching your surgery and knowing a little bit of your Hydras, would you think that since it stents a larger area, it would be more successful than iStent in your experience?
Yeah, so there's been a publication on this already comparing the Hydras to the first generation G1 2 iStents compared to 1 Hydras. And the Hydras was marginally improved in terms of IOP control, but it was a small study, a limited study with limited follow-up. My personal bias is that I believe that when you do target more surface area, you will achieve better results. And I think the company understands this, which is why the newest generation, the iStent Inject W, is 2 iStents on the same injector. Forthcoming will be the iStent Infinite, which will include 3 iStents to allow you to target a much larger area. So if you don't have the iStent Inject W, certainly 3 G1s may be very similar to 1 Hydras. So yes, I do believe that larger surface area will lead to a better outcome and more chances that you'll actually target those high freeway access areas where the collector channels are.
Are they ever been tried in a phakic eye?
Yes, the company currently in the United States, it is not FDA approved to be done as a standalone procedure, but in many parts of the world, in Europe, Canada, these eye stents and Hydras are being used as standalone devices, whether in phakic or aphakic, or sorry, pseudophakic patients.
Dr. Murli?
Yes, Dr. Craig, I wanted to ask you, have you ever had any late dislocations of these eye stent inject? I mean, anytime it has come out sometime later on?
Yes, for the eye stent tends to not move. I have seen improper positioning of the eye stent. We sometimes will get referrals where an eye stent is malpositioned, and I've seen it into the scleral spur. I've seen it into the ciliary body, which is often very irritating for patients. And I've also seen an eye stent first generation being deployed too superficially, where rather than being seated under all the layers of the trabecular meshwork, it is very superficially placed to split the trabecular meshwork. So in either of those cases, it can be repositioned easily. The Hydras is a larger device, and if properly positioned, it's very rare for that to be malpositioned if it's seated well. Now, the eye stent or the Hydras can actually come out of the canal and go down through the spur or maybe dive into the ciliary body. So it's very important that as you deploy the Hydras, initially maintain that 15 degrees. And as the device comes out, then you can start to level off a little bit. The problem with the Hydras is if you turn down towards the ciliary body or the spur, it will exit the canal. And so it's very important to maintain a level position to finish the Hydras microstent. Now, I have had one case that was extruded. Actually, about 2 weeks ago, a patient that I had to take back to surgery where the Hydras was malpositioned and it had extruded. And what we discovered is that the Hydras had come out of the canal and had gone in towards the ciliary body and was malpositioned. We thought it was in the right position at the time of surgery, but in fact, it was actually prematurely, or it was incorrectly deployed halfway into the canal and then going down into the ciliary body. So that was a very difficult Hydras to remove because it's a large 8mm device. I ended up causing a cyclodialysis cleft that I had to repair on the table. So it can be, it's better to reposition at the time of surgery or very early on if you're going to reposition rather than delaying that, because there is fibrosis that can occur around the device if it's deployed into the ciliary body.
Thank you very much. Yes, Dr. Harsh, you have something to ask?
Yeah, Craig, that was absolutely wonderful because we have just started doing these things. And your practical tip about how to avoid that strumming by, that was really, really wonderful for us. Two questions, because the way you just told us about the Hydras we don't have right now. So how comfortable are we with G1? We just started doing it. How much of pressure lowering can we expect with that, or should we just abandon it and go on to the inject?
Are you saying after G1, if G1 hasn't helped, would you just move on to iStent Inject W?
Yeah, W we still don't have, so we have the older version.
Yeah, so you have G1. My personal preference is if it's financially feasible for the patient, I would deploy more than one iStent. I feel that the pressure lowering with one G1 is minimal. Okay. Now you may get lucky if you deploy it in just the right area where you have a super highway, then you may get a very good result. So looking for aqueous veins, looking for areas that have high pigment might be your best zone if you can only deploy one G1. Okay. Now, something that I think would be useful in your situation is actually combining techniques, combining mixed techniques, maybe doing a limited goniotomy and then deploying one G1 in any direction, either to the left or to the right. And there you might achieve better results than just one G1.
Yeah, so the Hydras, the complication you just told us really scared us. So won't you think that instead of putting the Hydras, one could go ahead and do the injects? If you do 3 or 4 injects, won't it be, they'll be safer? Would you say it would be safer?
I think the iStent Inject W is certain, or even the G1, they're easy to place, relatively easy. I think with practice, the Hydras, here's why I like the Hydras. I'm biased towards the Hydras because the device tends to not only bypass the TM, it tends to scaffold and hold open that 90 degrees And so that's why I think you get better pressure lowering. Whereas an iStent injector, you're really just bypassing the trabecular meshwork, and you are maybe scaffolding a little bit in that area, but not nearly as much as you can with the Hydras. So I do think that with time and experience, you can avoid some of the complications that you see with the Hydras, and really maintaining that 15 degrees, reducing the gap from the injector. And one of the things that I commonly do now, I will say probably 90% of my Hydrases are done in conjunction with viscodilation. And that's done with an iTrack catheter. You can also do it with an Omni system. There are other systems being developed right now in order to viscodilate Schlemm's canal. When you dilate Schlemm's canal with viscoelastic, it makes it very easy to place the Hydras. It will slide in very easily when you expand the canal with viscoelastic. So I think that will be one thing to look forward to, is if there's a system that can be developed, either just with a small cannula to inexpensively dilate the canal prior to Hydras insertion. I think you can look forward to that as a potential option. But right now, yes, if you were trying to achieve the same results with a G1 compared to Hydras, you may have to deploy more than one.
Thank you.
Thank you. So we shall, thank you very much, Dr. Craig. I think you may not be able to stay for long, but we look forward to you adding your very wise comments through the course of the webinar, if you can keep your laptop on while the OPD is running. So
okay, I'll be driving to OPD now, so I'll try to listen. But thank you so much for the invitation, and have a good evening, all of you.
Thank you.